Dr. Richard Lam. I would appreciate if you could hold your questions till after his presentation, and then we'll allow Dr. Lam to answer any of your questions. You know, generally that lasts about 20 minutes after his talk is done, or longer, whatever. Dr. Lam is a board-certified internist and oncologist and has been specializing full-time in the treatment of prostate cancer since 2001. He is director of the clinical research of the Prostate Oncology Specialists, Inc. Dr. Lam has written numerous articles based on his research. He is an active member of the American Society of Clinical Oncology and the American Society of Hematology. Dr. Lam continues to promote prostate cancer awareness and education by giving lectures at various medical conferences and prostate support groups throughout the country. He is particularly interested in utilizing state-of-the-art therapeutics for advanced prostate cancer. Dr. Lam received his undergraduate degree in biology, magna cum laude, at UCLA. He then went on to earn his medical degree at UCLA School of Medicine before completing his residency training in the specialty of internal medicine at UCLA Center Health Services. He completed his oncology and hematology fellowship at Harbor UCLA Medical Center. Tonight, Dr. Lam will address what's new in prostate cancer treatments. There are many types of prostate cancer, and as you all know, many types of prostate cancer patients. Cancer treatments have improved, but side effects are still a major concern. Not everyone needs treatment. For the appropriate patient, active surveillance is the right option. However, we do have future developments, improving imaging and detection techniques, new highly effective medications, and more precise local therapies. The prostate oncologist specialists in the oncology group in Marina del Rey are made up of Dr. Mark Schultz, Dr. Richard Lam, and Dr. Jeffrey Turner. I am the CEO of the Prostate Forum of Orange County, and Dr. Lam is my doctor. Dr. Lam.
Thanks, Russ, for that very kind introduction. Hello, everyone. It's been about 4 years since I last spoke here, and it's great to be back. So the topic actually, what I'd like to talk about today is how we individualized the treatment of prostate cancer. You know, while most people in here are diagnosed with prostate cancer, almost every person in here has a different type of cancer, and so treating the prostate cancer it's not a one-size-fits-all type of approach. There's some men who are newly diagnosed who don't need treatment. There's some men who need surgery or radiation. There's some men who had those treatments and the cancer came back. Some men, all they know about having cancer is their PSA level being abnormal. They don't feel any symptoms. There are some men where the cancer is a little bit more advanced, which it has spread to the lymph nodes, bones, more advanced situations. So we really can't say that there's one treatment for every person in here that's going to work. So for the reason we exist as prostate oncologists is because this field is so varied, and there's lots of it's never black and white when I talk to patients about this. It's various 50 shades of gray in the prostate cancer world. So on that note, we'll get started. So this is okay. Got it. So just as a very brief overview, the prostate is a gland that's right above the penis, below the bladder. This is the bladder, this is the penis. And it is a gland that secretes fluid. And that fluid, semen, is what brings out the sperm when one ejaculates. And that's for reproduction, obviously. So as we get older, our prostates usually gradually enlarge. Some men faster, some men slower. And as that prostate grows, it creates more PSA. So a high PSA doesn't necessarily mean prostate cancer. However, we still have about almost 200,000 men diagnosed with prostate cancer every year. And of those, we still have between 25 and 30,000 men who die from this disease. It's the most common non-skin cancer in men. And about 1/3 of all cancers diagnosed in men are prostate cancer. It's the third leading cause of death, cancer death in men, right behind lung cancer and colorectal cancer. The risk of having a diagnosis of prostate cancer in one's lifetime is about 1 in 6. So the first, to confirm a diagnosis of prostate cancer, one needs to, usually have to do a biopsy. And so the first thing one faces in the journey of prostate cancer is to biopsy or not biopsy. And this is a main question that patients are faced, usually when their PSA is checked, sometimes without without discussing with them. And then patients are told, well, your PSA is high, you've got to consider a biopsy. Another reason for a biopsy is when the doctor does a prostate exam and the doctor feels an abnormal nodule. Okay. Another reason we do biopsies is when we see abnormal spots on ultrasound or MRI. And finally, not specifically, but there are some other tests that increases our desire or necessity to do a biopsy. And these are some of the new tests, one test being a 4K prostate score. And finally, if a patient has a higher risk of having prostate cancer, such as a family history, or he's already had a prior biopsy which showed some suspicious findings, that will increase one's odds of needing a second biopsy. So, because biopsies are actually not harmless, we really shouldn't just biopsy anyone without thinking through the pros and cons and actually what we're trying to achieve. So some side effects that can happen in men who get biopsies is, of course, some pain. One can get an infection or fever and infection. Bleeding occurs, and sometimes after the biopsy, one has difficulty urinating. In one study, up to about 4% of men who got biopsies were hospitalized due to some complications. I think recently or in modern day management, the risk of actually needing to be hospitalized is probably 1% or so. And even, there was a study saying that there's about a 1 in 1,000 risk of even dying from a biopsy. So I'm just going to do some interaction with you guys and ask you guys if we should do a biopsy on these cases that I'm going to present. So this is a 55-year-old man. He has no family history. His PSA was 6, and his digital rectal exam had no nodules. Should we biopsy or should we not? So you say yes or no if you guys want. Okay, so raise your hand if you think we should biopsy. Raise your hand if you don't think we should biopsy. Okay. So before jumping to a biopsy, what are some questions that one wants to ask to help us decide if we should do a biopsy? So that's right there. Excuse me? Size of the prostate. Okay, that's a good question. So the larger the prostate, the higher the PSA1 is allowed to have. Okay. So what's another question?
Previous biopsies.
Okay, previous biopsy. Sure.
Previous PSA score.
Previous PSA score. So you guys are on top of it. Basically, what this gentleman is implying is this PSA velocity worrisome? So was his PSA 6.0 last year and the year before? So has it really changed over time? If a PSA doesn't change over time, then the likelihood of having, if the PSA doesn't change over time, the likelihood of having serious cancer or even cancer is lower. Okay? If one's prostate is very big, the likelihood of having cancer on a biopsy is lower. Okay? Of course, if one had a prior biopsy and it was negative, we probably don't need to do another biopsy if the PSA is stable. Another case, again, a 55-year-old man. His younger brother had prostate cancer, but his PSA was only 1.9, but the doctor felt a nodule on the left side. Should we do a biopsy? So raise your hand if you think we should do a biopsy. Raise your hand if you don't think we should do a biopsy. Okay, so this is an easy one. Oops. The main reason this patient needs to do a biopsy is the doctor felt an abnormal nodule. The take-home message for this case is some doctors just check the PSA, primary care physicians. They don't even do a digital rectal exam. So they do a PSA 1.9, hey, that's normal, I'll see you next year. But if the doctor felt and did an exam and felt a nodule, he would have diagnosed this patient's case way earlier. There are some cancers that don't produce PSA. How about this case? 67, no family history. His prostate exam just feels like a very large prostate. Okay? So his PSA is 9. Should we do a biopsy? Raise your hand if you think we should do a biopsy. Okay? Raise your hand if you don't think we should do a biopsy. Okay, so about 50-50. The hint here is, the couple issues here is, number one, the patient's a little bit older, so he's had time to grow his prostate. And on exam, his prostate's very large. So before jumping into biopsy, we got to ask some questions. What was his prior PSA? Have we ever measured the size of his prostate? Has he had prior biopsies? So, in fact, this person, we've had cases like this quite commonly. This person's gland is over 100 cc's. Okay? The largest gland we've measured is about 300 cc's. That's about 10 ounces. Okay? So 10 shot glasses. Okay? So men who have big prostates can make a lot of PSA. Okay, so we've established some cases on whether or not we should biopsy. So let's talk about someone who's already diagnosed, who's gone through the biopsy procedure. So for every patient that gets a diagnosis of prostate cancer, we have to establish risk. Okay? The question of risk. What are the various factors that tell us if a person has high-risk cancer and low-risk cancer? And what I mean by risk is, what is the risk that there's cancer outside the prostate? In other words, what is the likelihood that when we take out or treat the prostate, that the treatment's not going to work? Okay? So, various factors that we look at include the PSA test, the digital rectal findings, the Gleason score when they do the biopsy, imaging studies to measure the cancer, to see if it has the size of the cancer, if it has broken through the capsule, if it has invaded the seminal vesicles, etc. And also imaging studies to basically look for cancer if it has spread into the bones or lymph nodes. Of course, if the scans show that there's enlarged lymph nodes or lesions in the bones, the patient's already high risk, or he's already metastatic. So now there are newer tests that we'll talk about in a little bit, looking at the genetic profile of the cancers, and these tests are called Prolaris and Oncotype. So, in general, as you guys probably know, the higher the PSA, the higher the risk the cancer. So anything under 10, 4 to 10, is considered good risk, and anything between 10 and 20 is intermediate risk. Anything above 20 is high risk. Of course, you have to remember these are just a general rule. So there are some men with high PSAs that are not high risk. For example, men who have a big prostate, men who have a prostate infection, men who recently ejaculated right before the blood test that caused a falsely elevated PSA. So digital rectal exam. So as you guys have probably experienced, so the digital rectal exam is when the doctor puts his finger in the rear end and feels the back part of the prostate. Okay? And if there's a nodule, it's a higher risk. If there's no nodule, it's probably a lower risk. And the exception here is the finger only feels the back of the prostate. The finger doesn't feel the front of the prostate. And cancers can start in the front of the prostate as well. Okay? So that's the flaw or the limitation of the garden variety digital rectal exam. So biopsy findings or Gleason score. Basically, I'm not going to go into the oops, I think this is a little, yep, okay. I'm not going to go into details, but the higher the grade, the higher the risk of cancer. And when the pathologist looks at the cells under the microscope, how he tells what a high grade versus low grade is, the low grade cancers still have what we call glandular formation. There's still some, there's less chaos to the slide. You still see some round areas. As the cancer gets more high grade, there's less of these ducts or tubes or glands in the cancer. So when it gets to the higher grade cancers, it's just a blob, a big mess. And finally, there's another type of prostate cancer that we need to be aware of, and that's called a neuroendocrine or small cell prostate cancer. These cancers are very aggressive. These are the ones that have a low PSA to begin with. You can have a big tumor and yet the PSA is normal, quote unquote. And these are the types of cancers that don't respond to hormone therapy very long, and they also tend to metastasize quickly and to stranger locations such as the liver, the lungs, etc. So back to the staging of prostate cancer. The stage 1 disease is cancer that's still within the prostate, and those are the cancers that usually are growing slowly. They haven't spread. Stage 2 cancers are nodules or cancers that are getting bigger. Okay? They're still on one part of the one half of the prostate, and they haven't broken through the capsule, but they're just getting bigger. Okay? Stage 3 prostate cancer has spread into the seminal vesicles or have broken through the capsule. And stage 4 cancers have spread outside the prostate into the bones, into these lymph nodes right here that look enlarged. The green ones are normal. This is the bone area where they have spread. It can even spread to the liver, occasionally the lungs. So that's stage 4. So again, let's go over risk again. So the higher the cancer volume in the prostate, the higher likelihood it has spread. The higher the PSA, same thing. The higher the Gleason score. And one more factor that I didn't talk about is the higher number of cores. So if your physician did a 12-core biopsy and only one core had cancer, that implies there's a less volume of cancer and therefore less likelihood of metastatic spread. If you have 12 out of 12 cores where every piece that the doctor took had cancer, that implies there's a lot of cancer in the prostate that the doctor couldn't even miss, and therefore there's a higher risk it has microscopically spread. Okay, so let's go over some interactive cases with some examples. We're going to just say, I'm going to ask you guys low, middle, low, intermediate, or high risk. Okay, so this is a gentleman who's 55. There's no nodule on the prostate exam. His PSA was 6.4. His Gleason score is 3+3. And of the 12 cores involved, 12 cores biopsy, one core had cancer. So, and the prostate gland is 60 cc's. Okay, so raise your hand if you think this is a high-risk case. Raise your hand if you think this is a medium-risk case. Raise your hand if you think this is a low-risk case. So, if you don't mind me asking, the guys who said intermediate risk, anyone want to speak up and say why this might be an intermediate case?
You know, it's a 12 course, there might be something else going on that you don't know about.
Okay. Well, the typical number of cores is 12.
I'm saying that there's 12 courses of prostate, but there's a lot of other area that has to be tested.
Sure, but those are areas, let's say we can't test everything, but given this information, would you say this is based on this information, okay, but it could be, right? It could be intermediate if there was some missing piece of information, but based on what we have. Okay. Anyone else?
We don't know what the doubling rate was.
Okay, so if we did know what the doubling rate, this is given what we have here. So if just because we don't have the information, it doesn't automatically put them into the higher risk. Okay.
Since you have a Gleason score, kill it before it expands.
Say that again.
Since you already have a Gleason score, kill it before it expands.
Okay, so that you treat it as, some people like to treat it as an intermediate case, but based on all this stuff, it's actually classically a low risk case. Okay, so let's go to the next case. All right, so this is the same guy, but this time the doctor felt a tiny nodule. His PSA is 3, his Gleason score is 6, his prostate is 20 cc's, and there's 4 of 12 cores involved. Okay, so raise your hand if you think this is a low-risk prostate cancer. Raise your hand if you think this is an intermediate-risk prostate cancer. Raise your hand if you think this is a high-risk prostate cancer. Okay, so this is kind of controversial. Okay, so if you look at these factors, 55 is fairly young, so it may bias into thinking, thinking things are treat them more like an intermediate patient. There is a nodule, although it's fairly small. Okay, and so usually a small nodule by itself doesn't automatically put you into the intermediate case. His PSA is 3, which is, some people would say it's normal. However, if you look here, his prostate's very small. So we didn't talk about PSA density. So for someone with a tiny, think of it this way, for someone with a small prostate, if so a small prostate should not make much PSA. So relative to the small prostate, this PSA is a little bit too high. So this is actually probably the case that nudges this patient into the intermediate category. Plus 4 out of 12 cores, it's not 1 out of 12, it's not 12 out of 12. So a lot of gray areas, but I agree with the intermediate voters. This is probably an intermediate case, okay? All right, next case. 65-year-old, no nodules, PSA is 11. His Gleason score was 3 plus 4. 2 of 12 cores involved, and the prostate size is 100. Low risk, raise your hand. Intermediate risk, raise your hand. Low risk again? All right. High risk? Okay. So, the people who said high risk, anyone want to chime in and throw out your ideas? Anyone think why this would be a high risk? Okay. So, some people would say this is a high risk, maybe because the PSA is a little bit high, above 10. But above 10 is actually an intermediate risk factor. Some people see that this number 7, it's not 6, it must be high risk. But 3 plus 4 is actually not bad. Okay? And in this patient with a PSA of 11, he had a pretty big prostate, which probably can explain a big percentage of this PSA. So this gentleman, he's a little bit older. Again, he's in the gray area between intermediate and low risk, but some doctors would even consider doing active surveillance for him. Okay? All right, last case, a couple more. 65-year-old, PSA of 18. There is a nodule on the right side and a little bit on the left. Biopsy shows 4 plus 5, 8 of 12 cores. Gland is 40 cc's. So everyone knows this is a high-risk case, so I'm not even going to ask you guys. Why don't you guys just tell me what are the things that tell you guys that this is a high-risk case? Anyone?
The Gleason score and the number of calls involved.
Great. Anything else? So the PSA is intermediately high, but based on the gland volume, it's pretty high. Okay, so it's called a high PSA density. So definitely a high-risk case. One more case, PSA 2.5. The left side is firm. Only 2 out of 12 cores involved. Fairly sizable prostate, so it's a good PSA density. Biopsy shows Gleason 9 with some small cell features. Anyone think this is a low-risk case? Raise your hand. Intermediate risk case? Raise your hand. Okay. High-risk case? Raise your hand. Okay. So most of the factors on this case, on the surface at least, 2.8 PSA, low number of cores involved, favorable PSA density, all suggest low-risk prostate cancer. Left side is firm. You know, that doesn't necessarily say it's a nodule. Okay, some less experienced physicians won't even notice a firm prostate. But the main message here is the Gleason score and the small cell features. So, looking, you know, when we evaluate a case, these are things that go through our mind and how we try to individualize a patient's situation. All right, so this is very basic regurgitation of what we just talked about. Low-risk patients have Gleason scores that are usually 6, low number of cores involved, very unremarkable or just a tiny nodule on exam, PSA less than 10. So how do we treat these patients? These men are very curable. So the cure rate, we're looking at 80, 90, 95%. Because there's an 80, 90, 95% chance that the cancer's still within the prostate. So these are the men that are very curable. So you can do all these options: surgery, radiation, brachytherapy, cryosurgery. There are newer options available where they're putting temporary seeds. Without radiation, just temporary seeds. They're doing very short courses of radiation, just 5 treatments over 2 weeks at UCLA. They're doing partial treatment, just freezing one side of the prostate and not the other. And of course, these are actually the men that active surveillance is very appropriate. Because it turns out that when we biopsy, patients who are just screened and routinely randomly biopsied, a lot of these men have only Gleason 6 disease. And a lot of these men end up getting treatment even though they're probably, don't need it. They're a little older, their cancer takes years, if not decades, to change, but they still get treatment. Okay. This is what was presented in the Journal of Clinical Oncology a couple of years ago. So the thought leaders in this in the field are actually asking, should we even characterize Gleason 6 disease as cancer? Okay, intermediate risk patients. These are men where the treatment still has a good chance of working, probably 60 to 80% success rate. The likelihood of dying from the cancer, even if the cancer was not cured, is intermediate, 3 to 10% over a 10-year period. And these are the guys who have these features: Gleason 7, a higher number of cores involved, a larger nodule on exam, and a higher PSA. Again, various treatment options. It's the same options that you consider that you would present to a low-risk patient. In some men, because there's a higher risk that the cancer is outside the prostate area, you might give them some hormone therapy to address the cancer that might be outside. These are the men you probably don't do active surveillance, but there are some cases you still consider it. Yeah, definitely. So, exactly. So, if you're 85, you don't remember who you are, and you just came out of the intensive care unit from a heart attack, you're probably just going to observe that patient. Okay, so the higher risk patients, these are men who have higher Gleason score, of the small cell cancers. They have a larger nodule. They have some evidence that the cancer's in the lymph nodes. The PSA is higher. So these are all men. If you treated the prostate, the cure rate's around 50-50. In other words, with these features, there's at least a 40, 50, 60% chance. Treating the mothership is not going to take care of the cancer because there's a higher chance it's already microscopically spread. So for these patients, you typically do radiation to the prostate, higher dose, that's called combination radiation therapy or dose intense. You usually radiate the pelvis. You give hormone therapy in conjunction with radiation, or in some men you just forego the local therapy and just give hormone therapy. Some men you add some additional experimental treatments such as chemotherapy or Zytiga. One can do surgery for these cases, however, there's such a high likelihood one's going to need radiation afterwards. Typically, we dissuade patients from doing surgery in these cases. So, all these treatments, often successful, however, they all have side effects, which we'll go over, including active surveillance has side effects as well. So we're going to go over all these briefly. Surgery, most common type of surgery is robotic prostatectomy, and this is where the surgeon is sitting at his console machine, patient sitting or laying flat here behind him. The surgeon can manipulate these metallic or metal arms with this gadget here. By manipulating this device, he can control these metallic arms. And it turns out that when I put together this talk, there was a lot of how would I say hoopla over the fact that, oh, robotic surgery, it's wonderful, it has no side effects. It seemed to give patients the impression that the likelihood of incontinence, erectile dysfunction, is going to be much better doing the robotic versus the traditional open prostatectomy. It turns out that the likelihood of incontinence, impotence, it's the same. Okay? The only minor benefit or moderate benefit is one can recover faster. One's stay in the hospital is shorter. If one is destined to maintain his urinary function or maintain his sexual function, he'll recover it faster. But doing the robotic doesn't necessarily improve one's risk of sexual function. Doesn't necessarily decrease the risk of impotence or erectile dysfunction and incontinence. It turns out that based on these studies, a lot of studies that basically the sum of the take-home message of many of these studies is the incontinence rate can be anywhere between 5 and 20%, depending on a lot of it depending on your situation and depending on who you go to. You go to the more experienced doctors, your incontinence rate will be lower. Also, a factor of incontinence is how old you are and how well your urinary function is prior. These are all factors that determine urinary function. Same thing with erectile function. With surgery, we're looking at approximately, in this study that was published about 14 years ago, this was a community-based study where they just surveyed the patients. And at a year and a half out of these 4,000 or 3,500 men, about 60% of the men said they were impotent. Again, the older you are, the less likely you're going to maintain your sexual function. The concept of climacturia, where when one climaxes, one actually urinates, was recently noted in the journal Urology to be as high as 1 out of 4 men. So after surgery, there's a 1 out of 4 chance that when you climax, you will urinate, lose control of your urine. So an alternative to surgery is radiation therapy, and it's usually performed via intensity modulated radiotherapy. Proton therapy is also quite quite popular and quite effective, but for the sake of this discussion, I'll just, basically, to me, the side effects are pretty similar. And the way the radiation works is the patient lays down. This is a non-invasive process, and the radiation machine, first they create a mold, a cast for the patient, and then the radiation machine emits radiation from all directions. And so, ultimately, the center of the prostate gets the most radiation. But because you're coming from various directions, there's quite a bit of a drop-off outside the prostate. But as you see here, the area around so the red is the highest dose of radiation. The green is less radiation, still about 64 gray. And the blue is the lowest amount of radiation, still, 20 to 40 gray. So we're not talking about no radiation outside the prostate. You're just getting anywhere between 20 and 70% drop-off of the radiation versus the prostate itself. So when patients often are I don't want to say misled, but they think that, oh, they're going to pinpoint my prostate cancer, just the lump within the prostate. But that's not true. When they say pinpoint, they're just pinpointing the prostate. And when they say pinpoint, it's not really pinpointing because there's still going to be some radiation outside the prostate. There's no such thing as pinpointing radiation to the gland without any radiation elsewhere. There's no such thing. Well, there's some exceptions, but the radiation oncologists do not pinpoint the cancer itself either. They treat the whole gland. So if the cancer's on the left, they treat the whole gland. If the cancer's on the right, they treat the whole gland. Okay? A little misconception, I think. So radiation therapy, because there's spread of radiation, it still can cause impotence, anywhere between 30 and 60%. Again, depending on your age, your pre-treatment sexual function. Urinary function, urinary complications actually are very low. 1 out of 3 men will have some urgency, frequency, burning temporarily. However, only severe urinary problems only occur in about 1 or 2%. But some men will have mild, chronic urinary issues, frequency, urgency. More importantly, though, there are some potential bowel movement problems with radiation. And during radiation, one can have frequent bowel movements, urgency to have a bowel movement. When you pass gas, you might have a discharge. When you wipe, you might see some blood. It's pretty common during the first couple months during and after radiation. However, about 1 out of 20 men will have chronic issues, chronic bleeding, chronic diarrhea that requires medications. So that happens in about 1 out of 20 men. So another option is brachytherapy. Brachytherapy is the implantation of these radioactive pellets or seeds into the prostate. So that's performed where the patient is under anesthesia. It's about a 1-hour procedure, and the seeds are placed via needle into the prostate using ultrasound guidance. And the ultrasound is inserted into the rear end, and the needle is inserted above that area, and the seeds are released into the prostate. And after the seeds are placed, they take an X-ray to make sure the seeds are placed in a evenly distributed area, so there's no cold spots. The whole prostate's addressed, and then they're done. So, so brachytherapy, the main side effect of brachytherapy is about a 1 out of 3, 30 to 50% of men will have also sexual problems. About 1 out of 20 will have chronic urinary problems, rather severe. So frequency, urgency, getting up every hour at night. When one urinates, there's severe pain. This could happen in about 1 out of 20 men. So how does one choose these various treatments? So surgery is usually for younger guys. I basically talk to patients about what side effect are you most willing to potentially get, or which side effect are you most scared of that you want to avoid no matter what. Okay? So once they think through it, it's the guys who choose surgery are the men who said, well, you know, if I'm in that 1 out of 20 incontinent, I'll deal with it. I just don't want to have my rectum burned. I don't want to have chronic burning. This is someone who already is having a lot of burning and frequency and urinary symptoms. So if you already have irritation and frequency, doing seeds or radiation on top of that, it's only going to make it worse. So someone who already has symptoms, especially when we calculate the AUA score, is really high. Those are the guys who probably would choose surgery. Someone who has a lower risk case where you cut it out and it's done, you don't need to do radiation afterwards. So these are the guys who choose surgery. They're usually younger because their bodies can tolerate surgery. They have less other problems such as heart disease or diabetes. Men who choose seeds could be young, middle age, older age. All men can take seeds, assuming they have a lower or intermediate risk prostate cancer. He's someone who doesn't want to do surgery, or we think surgery is a little too dangerous. Someone whose prostate's not too big, so you don't have to put that many seeds. And someone who's, okay, well, you know, if I burn a little bit, if I'm in that 1 out of 20, I accept that, let's do it. I'm more scared of incontinence than burning. So that's someone who chooses seeds. Radiation usually is for older patients. These are men who don't mind a little proctitis. These are men who do not have Crohn's disease or even irritable bowel syndrome or celiac disease. These patients, it's okay to have a bigger gland. These are men who have higher risk prostate cancer. There is some controversy about young men getting external beam radiation. There's probably a slightly higher risk of getting a secondary cancer from radiation exposure. So the younger you are, the longer you have to develop another cancer because you've had radiation to the prostate. It goes back to the slide I showed earlier that when one gets radiation into the prostate, there's still radiation in the surrounding areas. Finally, one of the newer options is partial cryosurgery or partial seeds. These are men who have lower volume, fairly low-grade cancer on one side of the prostate. These men, so that you can just treat the other side, but you still got to watch the other side that doesn't have cancer. And these are men who want to do everything they can to preserve their sexual function because partial treatment probably has the least likelihood of erectile dysfunction. Androgen deprivation therapy is basically the slide in a nutshell. So we don't have to talk about the side effects there. But basically, I tell patients androgen deprivation therapy is basically loss of testosterone. Men who don't have testosterone can have a lot of the side effects that women who go through menopause have. Hot flashes, night sweats, bone loss, dry skin, maybe some volatile moods, just not having testosterone. The other side effect of not having testosterone is it turns you into a little pre-puberty boy. So what are the characteristics of a pre-puberty boy? Thin bones, lack of muscle, lack of body hair, lack of sexual desire. So when we give someone androgen deprivation, we're turning him into an older woman and a younger boy simultaneously. Wonderful, isn't it? And then there's watchful waiting. This is a slide that a patient sent to us. And this young doctor is telling the patient, because of your age, I'm going to recommend doing nothing. So what about active surveillance? Active surveillance is a very popular, talked about term, option in the last 10 years. It's often confused with watchful waiting. Some people confuse it with expected management or deferred therapy. Our definition, or the official definition now, is We're monitoring lower risk patients, but we're still going to cure them when the time comes. So we're safely delaying curing the disease until the disease actually changes a little bit. Okay? And so the goal here is still to cure the patient. Okay? It's not to say, oh, you're old, let's just let the other diseases kill you. So it's pretty active in monitoring. Okay? Of course, the goals of these treatment, other than the goal other than cure, is also to avoid the side effects of the current available treatments. It's also for men who really want to avoid treatment and want to wait for newer treatments. And of course, the goal is to maintain quality of life. So this is the slide I showed earlier about Gleason 6 cancers being overtreated. Just a reminder. And a little short summary of the difference between active surveillance versus watchful waiting. The goal for active surveillance is to individualize treatment. Watchful waiting is just to avoid it, period. The typical patient is someone who is a good risk or someone who can get treated but chooses not to. This is a patient who's older and has a shorter lifespan, so these patients we tend to watch. The cancer stage, usually earlier stage, patients are in active surveillance. Watchful waiting is for any type of patient. The monitoring is more aggressive for active surveillance. For watchful waiting, it's less aggressive. And then these are the criteria for treating a patient on active surveillance. If there's any sign that the cancer is changing, for example, the PSA doubling time is changing, the Gleason score has changed. On the ultrasound or MRI, it looks the cancer is growing a little bit. Okay, so when the cancer has grown a little bit, you treat. Okay, that's the concept of active surveillance. Because sometimes the cancers don't grow at all for 5, 10, even occasionally 15 years. So one can be treating 5, 10, maybe 15 years too early. For watchful waiting, we're treating patients only if they start having symptoms. Only if the symptoms are affecting their quality of life. Okay. And for, finally, for treatment, so usually we treat for active surveillance earlier and watchful waiting later. And finally, the goal of active surveillance is, again, cure. And the goal of watchful waiting is quality of life, control of symptoms, and let the other diseases get that patient. Okay, so this was a study comparing treatment versus observation, no treatment. And this was a large study where they looked at over 700 men over an 8-year period, and the average age was 67 and the average median PSA was 7.8. Half of these men in this group had a PSA of 7 or above, and another half of these men also had a nodule. So a lot of these men who were on the study of treatment versus no treatment probably should have had treatment, okay, because they had higher grade cancer and a nodule. And some of these men ended up being observed only. Okay. So about 10 years follow-up, what they found is of the 300-something men who had surgery, there was still about 21 prostate cancer deaths. Okay. Of the 367 men who had no treatment, yes, there were 10 more deaths than the group that had surgery. So the death rate was about 8 versus 6%. So if you had a PSA of greater than 10 at the beginning of the study, the death rate was higher, double, 13 versus 6%. So they also saw that if your PSA was less than 10 going into the study, if you were either had surgery or watchful waiting, the death rate was not different. So this is implying that if you're on this study, by doing surgery or treatment, you're improving your death rate from prostate cancer by about 3%. Or you had to treat 300 men to have 10 less deaths. And if your PSA is under 10, treating probably would not have changed your death rate from prostate cancer. So this is a treatment versus watchful waiting study. Now they're doing a treatment versus active surveillance study, and all preliminary estimates really suggest that there's no difference in overall cancer survival, cancer deaths. However, if you had surgery, the incontinence rate is higher. That makes sense. The erectile dysfunction rate is higher versus, of course, if you had no treatment. And of course, some patients who do surgery, you can potentially die from surgery. You could potentially have a stroke from surgery, blood clots, heart attacks. One patient was put on dialysis because of after surgery. So, by doing surgery, you do save lives a little bit, but you also are at risk for some complications after treatment. Okay. So, how do we select low-risk patients or select patients for active surveillance? Essentially, we try to select lower-risk patients that we talked about. Okay? We also use other testing to further reassure us that it's okay not to treat the patient. So sometimes we get fooled. Oh, the PSA is low, the Gleason score is low, there's only a couple cores involved. We do an MRI, and we see a big tumor where the biopsy missed. We do an ultrasound, we see extracapsular extension. So we use multiple imaging modalities to reassure us that this patient does not have more cancer than what we're led to believe, the tip of the iceberg phenomenon. We're also beginning to incorporate genetic testing using these two tests, which I'll talk about in a minute. So these are some active surveillance studies that I compiled, and this is a study by Dr. Klotz, and it's been updated, but basically he followed 450 men who he felt were candidates for active surveillance, and they watched their, and after 10 years, they estimated that the likelihood of dying from prostate cancer was only about 3%. Of the 450 men at follow-up, about 8-year follow-up, about 5 men had died of prostate cancer out of 450. Now, people die of prostate cancer even if you get radiation or surgery, so don't forget that. And of the 4 out of 5 who died, 4 of them, their cancer declared itself within a couple years, meaning it started changing within a couple years, and therefore they were told that they should have treatment. And of those 4 that progressed during active surveillance, 2 actually decided not to get treated, and that's why that may have been the reason that there were 5 deaths. Okay. This is another study at Johns Hopkins where they followed 760 men. The PSA was 5. Gleason's the average age was 66. Most of them, these are very low-risk patients. There are no Gleason 7 patients, and most only had 1 or 2 cores positive. So these are, Hopkins tends to be a little bit conservative, so they're very choosy about who they study for active surveillance. And after, let's see here, I forgot exactly how many years followed. There weren't any prostate cancer deaths. So the take-home message from this study is if you have Gleason 6 disease and not too many cores, it's unlikely you're going to die from prostate cancer. So there's various, how we do active surveillance is a little bit variable. Dr. Klotz, they do a PSA digital rectal exam every 3 months for a couple of years, then every 6 months. They do a random biopsy at 1 year, and then every 3 to 4 years. Okay? Unless there's overt progression on other factors. This consortium here, they've been doing exams every 6 to 12 months. and they do a random biopsy at an 18-month period just to make sure the Gleason score hasn't changed, or that the biopsy, the first biopsy missed Gleason score, and then they do a biopsy every 1 to 3 years. Johns Hopkins, initially, they were doing biopsies every year as part of active surveillance. So it's a little bit invasive and aggressive, but since then they're actually less aggressive with annual biopsies. So the way we've been doing active surveillance, we check PSA levels every 3 months. We also do an exam every 6 months. We do an ultrasound every 6 to 9 months. We do an MRI to double check the ultrasound every year or so, year to 2 years. And if the patient has enough cancer, we try to do this baseline genetic test. And we usually don't do a random biopsy. We're more leaning towards lesion-directed or very targeted biopsies, primarily to just decrease the number of needle sticks that the patient's exposed to and to decrease complications. So again, just to go over how during active surveillance, typically the standard is to do a random biopsy, and again, random biopsies lead to these complications we talked about, transfusion, hospitalizations. The fact that random biopsies tend to, if you're not targeting a cancer, the lesion, you're probably less likely to learn more about the cancer. You're going to end up getting more Gleason 6 cancers and sample little cancers that were never going to present themselves or declare themselves. And you're going to decrease your likelihood of hitting the cancer and seeing, catching the true Gleason 7 or 8. So how do we target targeted biopsies? What are we basing our belief in target biopsies? It's the belief that with imaging, we're going to get better targets. And with imaging, we're more comfortable that the bad cancer's in a certain area and there's no there's no bad cancers in the other areas. So these are some studies on the MRI that basically show that if the MRI doesn't show anything worrisome, there's about a 90, there's other studies, but I would say a 90 to 95% chance there's really nothing serious going on. Okay. And this is a typical picture of an MRI. Okay. So this is the prostate, this is the rectum, and this is what we call the back of the prostate, where our finger exam goes. And this is the front of the prostate. Okay. And these are where the biopsy needles typically go, and they reach about 2/3 of an inch, 1.7 centimeters. These are the traditional random biopsies. The needles don't go to the front of the prostate unless typically the random biopsies don't biopsy the front of the prostate. So if you had a cancer, this dark area here, then the biopsy is going to miss it. So if you see a lesion on MRI, we try to target the lesion via MRI guidance or ultrasound guidance. So the random biopsy would have missed the lesion. This is a more obvious lesion where the cancer is on one side, and this is a normal prostate tissue. Just an example of what cancer looks like on MRI. So if one biopsies here, and the doctor did more biopsies here, just did a couple here, he may have only sampled this small part, but in fact there's a lot more cancer that was not sampled. So this is an example where imaging might have, will show us more than what the biopsy might have shown. Color Doppler ultrasound is another method. It's using sound waves to look at the prostate, and it's a little easier to do. It takes about 15 minutes in the office. We use it to complement or to in conjunction with the MRI, and we can track the lesions via ultrasound as well. And the ultrasound can catch things the MRI misses and vice versa. So that's why we combine both. This is an example of a normal prostate on ultrasound. This is a small lesion on ultrasound. See the dark spot here? It's only 7 by 5 millimeters. This is a larger lesion on the edge and the top of the prostate. There's a small one here as well. So the biopsy may miss this spot here and might just biopsy these areas. So when one biopsies target biopsy, one can put the needle in the dark spot. Finally, we're going to talk a little bit about genetic testing. There are 2 tests that are available right now. One is called the Oncotype genetic test. One is called the Polaris genetic test. Basically, this is looking at a patient who's already diagnosed. We're taking the biopsy, the cancer on the biopsy, and we're looking at the gene expression, the genetic pattern of that individual's cancer. And that genetic pattern is compared to a library of patients with various genetic profiles, and that comparison of the genetic profile can be. They'll look at with that library. They'll look at the group of men who have similar genetic profiles and see how they have done. So it's just a further step above digital rectal exam, PSA, Gleason score, in addition to those traditional old-fashioned risk factors and imaging. So the Polaris tests, these are the genes that they're looking at. They're called the cell cycle expression genes. And then based on the degree of expression, one can get a score on this. They simplify for us clinicians to give us a high score or low score. And this is an example of a case where this is a 62-year-old gentleman. He appeared to have pretty good risk prostate cancer, 2 of 12 cores, Gleason 6, PSH 3, normal clinical stage, and they did the Polaris score, which is a favorable score, right here, and it predicted, based on comparison to their library of patients, a 1% risk of dying from prostate cancer at 10 years. So this patient was basically reassured that he's based on the Polaris, he's another good reason that he does not need treatment so soon, and he's on active surveillance. This is another patient with a PSA of 5, 1 of 12 cores, 3+3 Gleason score, and his Polaris score was high, and it predicted that he had a 5% risk. He was in the top 1% of badness. And in this category, there's a 5% prostate cancer death. So he's someone who we would recommend not doing active surveillance. And he had a radical prostatectomy, and there was actually Gleason 7 disease, and stage 3. Okay, so that's how genetic testing is also helping us tailor treatment to the individual. So to summarize, basically we know that there's various successful treatments, and but we need to tailor them to the specific patient because there's so many different situations. We still have to consider side effects, and there are some patients who don't need treatment simply because their cancers are slow growing, and we want to, before we advise treatment or tailor treatment, we have to go over various indicators, how the PSA is behaving, what the imaging shows, what the biopsy shows, genetic testing, before we counsel a patient to choose the right path. And finally, just want to go over some new new things that are going on in this field, including better testing to stage patients, better ways to look for cancer. Of course, there are new medications that Mark talked about a few months ago here, and there are more precise local therapies, and such as partial treatment. And I'm just going to end on a couple of fun slides. We've been using the carbon-11 scan at the Mayo Clinic and Phoenix, Arizona Molecular, and sometimes UCLA. A carbon-11 scan is a test that, a nuclear-based test that helps us localize where the cancer is. It's probably going to pan out to be more sensitive than CAT scans, bone scans, and hopefully we'll get FDA approved for the general public to help us manage patients. This is a gentleman who had a prostatectomy, and his PSA rose after surgery. He had a Gleason 8. PSA was doubling not too fast, and on the carbon-11, he had some increased activity in the prostate bed. Therefore, he had radiation therapy. He was counseled that, well, it didn't light up anywhere else. That means there's a good chance the cancer is only here. So the patient underwent radiation, and the PSA continues to drop, and there's no evidence of relapse yet. Okay, that's one case. This is another case where a patient had prostatectomy, Gleason 8, had a positive margin. At the after surgery, he had a PSA was 0.5. They did a carbon-11 scan, and it lit up here, and the patient also had radiation therapy. This is another case where, find the spot. So, let's see here. Okay, I see it. It's up here. So this is a gentleman who had surgery. PSA was 0.4, 9 months after surgery. Carbon-11 showed a little spot right here. This spot probably would not have been picked up on the traditional CAT scan. And so rather than radiate just the prostate area, this patient had radiation in the prostate area and the spot to hopefully give him a more likelihood of achieving remission. Imagine if this patient, without the carbon-11 scan, had radiation here, it probably would not have changed his prognosis because the cancer was already here. So this is another case where the carbon-11 test will help. And this is just a case where there's a metastatic spot right here. Anyway, so we're trying to incorporate, not everyone gets a carbon-11. We have to decide if it's really going to change how we manage a patient. Right now, Medicare does not cover it. It ranges anywhere between $1,500 to $3,000 for the test. And on that note, I believe we're done. Let's see here. Oh, another spot. So on that note, we're done. Please I would continue to get prostate exams and PSA screening. And it's just a matter of, if you do have prostate cancer, you need to have someone help you tailor your treatment. And this is a little advertisement for my partner's book, and also the PCRI conference. And we've also left some brochures in the front if you guys want to refer to that. And we have some time for questions. Thank you.
Okay, if you're going to ask a question, raise your hand because we want to get you on the microphone because that's what's going to pick up for our video camera. All the way in the back. Make me walk that far, just the first question.
Do you think at some point they'll start using the therapies with a lower PSA instead of waiting until there's disease signs?
if we go by a lot of the other cancers, we're using treatments for advanced late-stage cancers earlier to try to improve the cure rate. That would be the goal of using these newer treatments up front. And it takes a lot of studies, a lot of participation in clinical trials. It's a little challenging to use these medications up front without studies because these drugs are very expensive. Right now we just got data for men who have metastatic disease, who have not failed hormone therapy, to use chemotherapy simultaneously before they fail hormone therapy. And that's showing that people do tend to do better and live longer if they get chemotherapy before hormone therapy wears off. Will we ever get new drugs, for example, right after a patient has surgery or right after the patient has radiation? Can we give them a dose of Provenge? Can we give them 6 months of Zytiga? I hope so, but it's going to take a while based on the lack of studies and the difficulty in doing studies. The challenge is, as you guys are probably aware, prostate cancer, prostate cancer, even the more advanced or aggressive cancers, these patients live 5, 10, 15 years. They live a long time. So in order to prove that adding a new drug on day 1 makes a difference, they have to follow these men out 10, 20 years to see if there's a survival 10, 20 years from now. You won't see an obvious survival benefit using new drugs for prostate cancer because the natural history of prostate cancer is so long. So that is a challenge as well. Next question.
Could you talk about active surveillance combined with diet?
Yeah, sure. Anyone with prostate cancer, early or late stage, I think diet has a component, and for probably lower risk patients, for slower growing cancers, a good diet low in fat and low in sugars will probably slow down a slow growing cancer. For every patient in our practice, we definitely support that. And plus, the number 1 cause of death in men with low-risk prostate cancer is heart attacks. So I ask patients to have a heart-healthy, anti-diabetes diet just to prevent those complications as well. Next question.
You indicated that the larger the prostate, the less likelihood. I have a question about a large prostate and treating it with radiation. And can it be too large to be treated with radiation? And thus they have to take other methods?
Sure. So for seeds, we have to have a smaller prostate. For external beam radiation therapy, they can radiate up to 100, 120 cc's. A lot of it has to do with what the patient's pre-existing symptoms are and what the likelihood that he'll have urinary blockage after radiation. So sometimes if the prostate's too big, hormone therapy can shrink the prostate first before doing radiation therapy. But because they pinpoint to the gland fairly well, they're able to treat larger prostates.
Can you talk about the difference between Lupron and Firmagon, is it?
Sure.
And when is one indicated over the other?
Okay, so Lupron, basically Lupron, they both end up telling your one's testicles to stop making testosterone. Firmagon works faster. Firmagon, does not have a what we call a testosterone flare. So when we give people Lupron, within the first 2 to 4 weeks, their testosterone level temporarily goes up and then drops. And it may not drop as low as when one is on Firmagon. When one is on Firmagon, the testosterone doesn't go up, it just goes down, and it reaches a low level quicker. So for certain patients where we need to get a very fast response, we do Firmagon. Otherwise, if someone is already on Lupron and they're doing well, there's no need to switch to Firmagon. It's a little bit more uncomfortable, and they only come in once-a-month injections. Yes.
Dr.
Oh, yeah.
Lam, could you explain the Gleason score in layman's terms?
Sure. So it's basically Dr. Gleason categorized the higher the Gleason score, the more chaotic, the more aggressive the cells are. And the way one decides if a Gleason score is high or low is what it looks like under the microscope. And these pathologists have certain criteria for what is chaotic and what is not chaotic. So, and the degree of chaos is a good indicator of the aggressiveness of the cancer cells. Aggressiveness meaning the degree, how fast the cells are replicating.
So does that mean any Gleason score is a, so does that mean that any Gleason score is a cancer score?
That's, yes, well at this point they don't, anything Gleason 6 or above is cancer. If they call something Gleason 4 or 5, today that's no longer considered cancer. So if they say you have cancer, you have to have a Gleason score 6 or above.
Yeah, you mentioned, doctor, about the preciseness of radiation. And we hear like City Hope and the proton, and that they are very precise. It doesn't go out. They aim it precisely. How correct is that?
Well, it's a little bit misleading in that there is radiation exposure to the healthy tissue in front, below, above the prostate. Luckily, that even though those areas get exposed to radiation, they don't get damaged because the body has a certain ability, it can tolerate a certain amount of radiation. So it's not like the prostate gets 100% of the radiation and the bladder gets nothing, no radiation. The truth is, the prostate gets 100% of the radiation, and the rectum and the bladder gets about 50%. But 50% of the radiation is usually harmless.
You mentioned also, doctor, that the biopsy doesn't show where exactly the cancer. If the cancer at the front and testing from the rectum, they test the lower part of the prostate. Is the ultrasonic will be more precise?
So the biopsies, of course, the urologists, when they do biopsies, they do label where the samples came from. And so the biopsies tell us where the cancer is, where they biopsy, which is the back of the prostate. Some urologists do a couple samplings of the front of the prostate, but they don't do 12 in the front. So if they don't hit the front of the prostate, and if there's cancer in the front, then they will miss it. And in those situations where, let's say the PSA is elevated and the biopsy was clear, and we're still worried, are we missing something? Then imaging will help. Either ultrasound or MRI, or you need both. And, you know, there are some cases where even imaging doesn't show the cancer. Then it's even more challenging.
You showed a pathology of something that is more cancerous than a 9, 8 to a 10. How would that come back as a number to 1? And you say it doesn't respond well very long to hormone therapy. How long is not long?
Sure. So not long is less than 2 years, I think. I mean, there are some men who respond to hormone therapy for 10, 15 years. I would say a couple of years is not long. Then the hormone therapy stops working and the cancer grows, either manifested as PSA or imaging findings or symptoms.
You didn't speak much about focal therapies. Focal laser ablation seems to have given some people excellent results with virtually no side effects. Could you comment on that?
Sure. So I believe it's Dr. Sperling. He's doing a lot of focal laser on the East Coast. And hey, I'm a believer of focal therapy. Simply, logically speaking, you're treating less of the prostate. You're trying to not affect the nerves and blood vessels around the prostate. The key is knowing where to treat the cancer. So you have to have very good testing to be sure that the cancer is only in one spot. So we still need a lot more data. So the smaller the amount of area you treat on the prostate, yes, the lower the likelihood you're going to have side effects. The main question is what happens long term? Did you really get it all? Or what happens to those patients who great, he has no side effect, but a year later the cancer was still there. So we need more information and data before we start sending everyone to laser therapy. But it sounds and it's theoretically it's very attractive. But the key is knowing where the cancer is. Any other questions?
Yeah, Dr. Lam, if Lupron stops working, will
Yes.
Firmagon continue to work?
A small percentage of men have a response to Firmagon when Lupron stops working, but usually just for a few months.
Forgot what I was going to ask.
All right, anybody else?
Somebody that's had surgery and the margins are been show signs of cancer. What are the advantages of hormone therapy at that point versus radiation therapy?
Sure. So you said the margins are positive. Okay. Well, when one has surgery and there's positive margins, one can get radiation to that area, and the intention of radiation in this situation is to cure the patient. Okay. So that is the intent of radiation. If one does hormone therapy, it's merely to control and prevent it from spreading. So it all depends on what your intention is. So if for example, after surgery, I could say, I guarantee you're going to get cured with radiation. Most men will say, okay, I don't mind some potential rectal damage. I don't mind a little leakage. I'll do it because they guarantee I'm going to get cured. But realistically, the cure rate's anywhere between 20 and 70%, depending on your situation. And that's where the main discussion comes, the thinking process goes.
Is there an MRI guided HIFU around, and how effective is it?
Is there an MRI, pardon?
MRI guided HIFU.
I don't think so. I think HIFU is still ultrasound guided. They just started doing MRI guided biopsies. So maybe the next step would be MRI guided HIFU.
Could you comment on radiation over a shorter time, like 5 days or within a week, as opposed to over 6, 8 weeks?
Sure. So the newer the new approach to radiation, traditionally radiation is given over 8.5 weeks, 5 days a week for 2 months. So the patient goes in daily for every day for 8.5 weeks. And of course it's a hassle, but the prostate's getting a little bit of radiation every day. And for example, for brain cancers or spinal cancers, they perfected something called gamma knife or stereotactic radiosurgery, where you get the radiation at a very high dose, pinpoint it one time, maybe 2 times. So they're applying that high dose one-time treatment to treating the prostate with less treatments but a higher dose. And so what Dr. King at UCLA, Dr. Fuller at San Diego, they're doing about 3 to 5 treatments over a 1 to 2 week period. So it's a higher dose, lower number of visits. It's a little too early to say what's the long-term effects. The first few cases 3 years ago that we encountered at UCLA, the patients had a lot of acute bowel issues and urinary issues. I think my impression is they're getting better. The UCLA is getting better. So we need some long-term data to see if ultimately the side effects are going to be better or worse, and if the cure rate is going to be better or worse. But, you know, that's where it's going.
The gamma knife is very similar to cyber knife, right?
Yeah, I mean, there's so many different names of... The concept is high dose and try to pinpoint and do as little scatter as possible.
Well, it looks like that's all. You guys had a lot of questions tonight. There must have been a lot of interest in this presentation. Dr. Lam, we really appreciate you coming here tonight. I'm sure we've all learned a lot. And as you well know, I can't afford to give you any money for coming here. But I can save you time, as time is money. And here's a prostate foreign cup that fits in your coffee. It fits in your car so you can drink your coffee on the way to work and you don't have to waste your time. Please give it up for Dr. Lam.